the Medical AI Podcast.
Welcome to the Medical AI Podcast with me, Dr. Felix Beecher. Strap in for a 30-minute thrill ride of big ideas. In the US, over 1 million people per year will need urgent life-saving treatment for a heart attack. But these treatments are risky for the patient and can be potentially fatal. How can AI help predict potential So this is why I need a few takes, man. You're not going to need these takes. How can AI help predict potential adverse events to treatment and help mitigate those risks? Well, with me to discuss this life and death issue is Ben Tasker. Ben, a very, very warm welcome to the podcast.
Thanks for having me, Felix.
Absolute pleasure, Ben. So could you please introduce who you are to the audience and a little bit about what it is that you do?
Absolutely. I'm Ben Tasker. I'm an AI expert who's worn many AI hats. I've been a data scientist, an AI engineer, a product manager, and today I serve as the Dean of AI at one of the world's largest universities.
Which university is that?
It's Southern New Hampshire University.
I'm sure they'll be very keen to listen in. Okay, good. So tell us a little bit about what you do in this space.
Well, my AI journey actually didn't begin in a university setting. It started in a hospital. And at the hospital, I was trying to solve a very human problem. Mm-hmm. I was asked to forecast patient volumes for doctors' offices, and I wasn't even a data scientist yet. I was just someone that had some Excel and some light coding skills. But what I found shocked me. Some facilities didn't have structured data at all, just estimates or best guesses. And that experience pushed me to an upskilling journey where I then earned my master's in data science and analytics. And it taught me a foundational truth. Data is the oil that powers the AI engine. And that theme, data is fuel, is what I want listeners to remember as we dive into today's topic. I now focus on developing the AI engines that power products, algorithms and logic that make sense of real-time data. One project that's close to heart, quite literally, is about using live waveform level data to predict serious adverse events in the cardiothoracic intensive care unit before they happen.
Good. All right. Well, look, before we get into the details of your particular system, why don't we talk about the problem that you're addressing with it first? So could you speak to that? So, for example, how serious is heart attacks a problem in the US, for example?
Sure. So about 6.57 million individuals may go into the emergency department, the ED, or the emergency room, the ER, with what's considered chest pain. 1 million of those individuals would then have a critical case of a heart attack, meaning that it's either already happened or it's about to happen. What we're trying to do is that we're using waveform data like heart rate, oxygen levels to help AI spot early warning signs in critically ill patients. The goal is to give doctors real-time explainable insights so they can intervene faster and save lives. I have a little bit of an analogy to go into before we get to that critical care, but I think a lot of individuals have experienced this. But let's pretend you're at home watching TV. Then you start to feel a strange tightness in your chest. It's not sharp, but it's heavy, like someone's sitting on your ribs. It doesn't go away after a few minutes. Then they notice your left arm starts to ache. Your jaw starts to feel sore. You're feeling short of breath. Just walking to the kitchen, you also start to feel nausea. But it's not from something you ate, it's very deep inside your stomach. Many individuals at that point realize that this is something more serious. They either decide to wait or call out to someone for help. They then enter the emergency room if they call for help. And whether you enter the emergency room or you're picked up by an ambulance, a few things are going to happen. You're going to be given a low-dose aspirin to thin your blood. Your blood pressure is going to be checked. You're going to be given a pulse oximeter to check your oxygen levels. And most importantly, you're going to have to go through what's called an ECG, an electrocardiogram, and that tests your heart's electrical rhythms to see if anything abnormal is going on. Just right there, just before we even get to that critical case, a lot of data is floating around creating that oil, so to speak. Age, gender, medical history if you have any, and the symptoms of the pattern. For men, chest pain is a huge red flag. For women, it's often more subtle. It could be the nausea, the back pain, or just the fatigue. And that's why these details matter. Depending on how the ECG goes, you might even be asked to draw blood. And in that blood draw, there's very specific markers that can show if your heart's going under stress. That lab data is also imperative to the model that we're building.
Yeah. And could you just explain a little bit about what a heart attack is so that we really understand what's going on here? Because a lot of people might be thinking, well, a heart attack is when your heart stops and then you're basically, about to die. But that's not quite true, is it? So could you just explain how we define heart attack?
Sure. A heart attack is when an individual has a blocked artery or the heart's rhythm becomes faster or slower than average. So depending upon one of those situations, two things will occur. So going back to our story, after you have your blood drawn, a cardiologist would be called down to the emergency department, and they would need to decide one of two things. Either you are going to have a heart attack, or you already had one, or maybe the third is maybe this is just built up gas or anxiety, but then those patients leave. But if you do need surgery, that's when things really get serious. They take you to the surgical area of the hospital, and if they can figure out where the blockage occurs, I kind of like to relate this to a train station. They have to lay the tracks first. So they have to literally follow your blood vessels down to where the heart blockage is, and then they have to put in a stent, which is the train, to open up that artery so that blood can continue to flow throughout your heart. In some cases, that may not be enough, and an even more serious case is when they need to do what's called a bypass, and with bypass surgery, they bypass the artery so that blood can continue to flow throughout your heart. So even just going in with basic chest pain could lead to something way more serious, and that's why these tests are critically important.
Okay, so you've talked about a few kinds of data that can be collected even before you arrive at the hospital, such as ECG, blood pressure, oxygen saturation, and so forth. Could you just explain a little bit more about what those data are and what they are measuring?
Sure. So blood pressure is the amount of blood that's flowing through your body. Oxygen rate, usually around 90 is good. It's just the amount of oxygen in your body. If it's too low, that means there could be lung symptoms, and your heart and lungs usually operate together. What was the third measure that you needed, Felix?
Well, ECG, I think would probably be done in an ambulance too, right?
Potentially. But either way, even if it happens in the ambulance, it would still be done in the emergency room just to make sure that whatever happens in the ambulance, because it's not as high tech, is accurate. The cardiologist would probably want a second read just to double check.
Okay, so Ben, could you talk us through a little bit more about how your system adds value for the clinician and the patient here?
Sure, absolutely. So at this point in this story, the patient made it to the surgery, and then they made it through the surgery. So the surgery was successful. The surgeon was able to remove the blockage in the heart. It really didn't matter if it was a stent or a bypass, because the next step is going to what's called the cardiothoracic intensive care unit, the CTICU. And in that unit, you're monitored just to make sure that you get healthy again. And sometimes patients need to stay in that unit a little bit longer because there's complications. So picture this very high-tech area with monitors all around you. and a very highly trained clinical team of cardiologists, nurses, maybe physician assistants, and they're looking for key signs of infection, sepsis, if you're going to have a relapse, maybe even a stroke. And these technological devices around you give measurements or reads. And if you go below or above a certain reading, that means there could be some sort of complication. So then the cardiologist has to figure out how to best serve you. What's different with the AI algorithm that I've been working on is that it uses live waveform data. So about every 5 minutes, these bedside monitors collect all the information that's traditionally collected, the blood pressure, the oxygen rate, the CO2 rate, the carbon dioxide rating is what I'm trying to say there. And if there's a pattern, that could indicate declining health. So this algorithm can then tip off the clinical team before the monitor would, because it sees that trend over time more quickly.
Now, I suppose, not being a cardiologist and being somewhat naive, that it's possible that what we have here is very, very rich kinds of data. We have waveforms, time series data, and we have lots of different measures such as airflow, oxygen saturation, breathing rate, and so forth. And there may be many cases where these kind of data are giving a very clear signal to the cardiologist that something is wrong. But there may also be cases where these data can give that sort of information, but it's really not clear to the cardiologist, because maybe that information is hidden away in complex relationships between the data, and that's where the AI can really add value. Is that sort of more or less the case?
That is absolutely the case. So looking at the historical data in our data set before we started looking at it in real time, we noticed that the patients that had the adverse events, the fraction that did eventually pass away or needed another type of surgery, they started to trend, for example, on oxygen rate lower and lower over a series of days. Sometimes 2 or 3 days. But they didn't tip off the monitor or the clinical staff. And this really isn't a clinical failure. They were still above average. They were still doing well. But then it gets really serious when they stop doing well. So by having a guiding force behind you that puts these statistics directly in front of you, that could have intervened and saved those individuals' lives.
And are there any particular case studies that kind of stick out in your mind to illustrate the point and how this could work?
There's a couple case studies about how this all works. Just to help break this down a little bit, I don't really, this is a data science issue, what we're doing, but ultimately we're trying to save lives, and that's the imperative issue here. So it's a very human-centric approach. 1 in 5 ICU patients have some sort of serious adverse event. In CT ICU cases, the longer that you stay there, especially beyond 30 days, the risk of mortality increases by 25.6%. That means that if you had a 20% risk of death on day 30, on day 31, that's now 45.6%. So it just keeps going and going until you eventually are no longer living.
So have you seen particular patients in which this kind of system worked, and what happened? What kind of symptoms did they get, and do you think that the lives were saved in the case?
Yeah, absolutely. So we're still testing this data. So we collected 5 years worth of data from 2018 to about 2024. That's what we consider historical. And this algorithm isn't facing patients or clinicians yet. We do have it run in the background, and we are collecting the waveforms live, and we're testing to see if this waveform model is more accurate than a current algorithm that's currently placed on the floor.
Now, when you're talking about waveforms, which waveforms do you mean in particular?
Sure. So waveform data is considered dynamic data, so it's live. Mm-hmm. So it can come from the bedside monitor, like heart rate, blood pressure, your air saturation rate. In some cases, the patient needs more critical care and attention, so they might be connected to a ventilator. So then that would measure air intake and outtake to see if the patient's still breathing. That's what we consider waveform data.
I mean, the reason I'm asking is because let's think about airflow, for example. Airflow in and out of the lungs is going to form a kind of a wave, right? But on the other hand, temperature, I guess, is sampled every, I don't know how often, but it's going to form a wave. It's going to form time series data, but not what I would call a waveform. You see what I mean? So,
very correct. So the reason why blood pressure is important is because if it begins to drop even subtly, it could be by 1 or 2. It could mean there's a leading cause to infection. So thinking about what a CT ICU patient is, in the most critical cases, they've had their heart operated on. If they have a stent or something connected to their heart to help prevent infection, that means there's a line from the outside environment connected to one of the most critical organs in your body. So that's why that waveform data is important, because as it updates every 5 minutes, even if there's not a sign of infection yet, that doesn't mean there can be.
I see. Okay, so currently you are doing research not just for developing the system, but also testing how much value the system adds for patients or for health systems, correct?
Yes.
So could you just walk us through what kind of research you are doing of that kind, and if there's any results that are provisional and maybe you want to talk about?
Sure. I think it's important to talk about the current system a little bit, just so we have something to compare it to. So that current system that most healthcare systems use is called the STS risk score algorithm. It's the Society of Thoracic Surgeons algorithm. It's been around for decades. It really has 6 main inputs, those 6 being the patient demographics, medical history, cardiac function, what happened during the surgery, what happened after the surgery, and institutional factors. What's your success rate amongst all patients with similar conditions? And then that outputs, it uses a very simplistic way to output all this. It's just a yes or a no, indicating some sort of mortality risk. So the higher the percentage, it means that you're closer to death, and the lower means that you're further away from it, but doesn't really specify where or how. Our system, and I guess before I keep going, it's important to understand that even though it is using the live data, the way the clinical teams use it now is very static. So it's all historical data. So it's not using that live iteration to see where the patients are in time.
Now, I suppose, though, that what you could do is incorporate those kind of historical pieces of data with whatever system you're using to analyze, real live time series data. I mean, do you do that?
So when we entered this research, we actually were just looking at waveform data, and just looking at the waveform data alone, it still produced slightly better results than the STS algorithm, about 1 to 2%. So depending on the patient's complications, the STS algorithm, the standard algorithm, produces between 77 to 85% accuracy. And our model produced, with just the waveforms, a little bit above that, but it's a statistical indifference. So then we went back to the clinicians and we asked them what other ways we could enhance this model. And anytime you check into a hospital, especially if you were a previous patient there, they have what's called an electronic medical record. And it's a fancy way to have all your data stored in a database. Previous labs, previous diagnosis, if you've moved, your environmental factors. And that keeps updating every time you go into the system. So to your point exactly, that's considered static data. It's not really live. It's live in the sense that it gets updated when you're there, but it's not live every 5 minutes connected to a monitor. Connect that to the static data, the waveforms, and then we actually saw a big jump in our model's accuracy to about 89%.
But are you also using the kind of data in that standard test as well, or just the data that is readily available in medical notes?
By standard test, you mean in the the waveform model, or the
No. The test developed by the Association of Cardiology, or whichever it was.
So that test is just static. So if it's in the system, they use it, but in most cases it might not be in the system. Ours updates automatically. So if you did get labs, as soon as the labs hit the electronic medical record, it gets the reading into our algorithm.
I see. Okay, so the upshot is that your system provides a meaningful and significant jump in terms of predictive accuracy compared to what is currently done, right?
And it's minutes, and minutes might not sound that imperative, but these are very critical patients, and minutes could be the difference between something, an organ failure to entire body system failure. And there's also some hospital value or institutional value to this. So adverse events, because of how insurance works in the United States, usually costs healthcare organizations money, and that ranges between $26,000 to $48,000 depending on the event. And just to occupy a CT-ICU bed costs about $5,000 to $10,000 per day. So by trying to implement more critical care faster so these patients heal quicker, you're actually reducing the cost per episode, and you're ultimately reducing the time in bed, so that eventually the patient can be released back out to society with hopefully low hopes of readmission.
Okay, good. So there's a win-win here. There's an economic benefit for health systems, and there's also a win for patients. So that sounds fantastic. So how are you finding the project of getting these kind of systems integrated in healthcare in reality? What kind of challenges are you facing?
A lot of folks are still afraid of AI. They don't realize how AI can amplify a role. And that's especially true in healthcare. I've heard from a lot of clinical staff that they didn't really want AI involved in their clinical decision making. I've heard the healthcare system didn't really have much training around AI. And I think those are very fair statements. So where we are at is we're trying to not only showcase the value of AI, but we're also working on AI upskilling and reskilling. So that when individuals do have this in front of them, they're able to utilize it. And it's not really a clinical decision-making tool. It's more of a early alert system. It's another tool in the toolbox, so to speak.
And how is that going? I mean, do you have a feeling that the attempt to get people to look at AI systems in healthcare in a more friendly way as being something that is improving over time, or are you facing sort of more militant, hardening, sort of Luddite attitudes?
Yeah, I think it's really important to understand that this is in a rural health setting, and even though there's other types of technology that do something similar, the data that we're training this AI tool on is all from that healthcare system. So this isn't a one-size-fits-all approach. It's a very human approach, and we really needed to also emphasize the value. So just taking the basic average numbers of the $35,000 cost and multiplying that by 890 patients, there's been 1,000 patients with adverse events. So at 89% accuracy, that's how we got 890. That would save the healthcare system $31.15 million, so about $31 million. And the traditional system saves about $29 million. So we saved 40 additional lives if we were to enact this, and we saved an additional $1.5 million. So that's not only helping the individuals, but with that $1.5 million, the healthcare system can invest in other areas, improving patient care.
Okay, good. Now, what we have done, Ben, of course, is touched very briefly on a much broader issue in healthcare systems. And maybe you could explore that a little bit more. And I'm talking about data integration, because what your system relies upon is that the kind of data that is present in medical records is readily available to be fed into your AI system. Now, could you talk a bit about this broader issue a bit more? How big an issue is this, for example?
Sure. I really think it's important to think of AI like a system, just not a point solution. So going back to our original story, when an individual just had simple chest pain and they checked themselves into the emergency department, we started gathering data as soon as they walked through the door, right, with that EKG. Typically, the EKG data isn't used to influence anything besides just a read. So by having that data and having that over time is very critical. It's also important to understand that the clinicians are still in charge of all this. They're still making all the decisions. So as AI becomes scary and there's a lot of negative press about it, so to speak, in this situation, without it, the clinical staff, the physicians, wouldn't have what they need quick enough. So they would just go back to proven ways, but in some cases they're not saving everybody.
And what attempts are there currently to work on this problem of data integration in healthcare in the US?
Sure. So I think it's also important to understand that just in that story, they started in the emergency department. Then they went to surgery, which is a different department. Then they went to a post-op area, just where they recover a little bit. Then they go to the cardiothoracic ICU. So just right there, that's 4 different handoffs. So the system, even though it's connected and they call it a system, and there is that data, and I know the clinical staff look at it, there's really not that AI ecosystem. They're not using AI throughout the entire process. They're using different algorithms throughout the way, or evidence-based medicine that's been clinically proven to make sure that the patient gets the care that they need. And it's usually very effective. But the benefit of coming over some of these fears, and by showcasing what waveforms can do and increasing the education around AI, and remember, clinicians are some of the highest trained staff, and they're still resistant and may not know how to use AI. By building that culture and slowly showing that return on investment, they're becoming more willing to utilize this technology, utilize this data, and the next steps are what's considered a preclinical trial. So they would then look at the results that we have been collecting and comparing it to results in real time to hopefully gain FDA approval.
Got it. Okay. All right. Well, look, Ben, I think you've given a magnificent account of a very interesting area. However, I'm going to free your mind outside the bird cage of cardiology, and I'm going to ask you my last question, which is, out of anything in medical AI, what is your favorite example of a system out there?
Sure. So I usually talk about education, and this is healthcare adjacent, but it does tie back into waveforms. There are educational technologies, so think about like Apple Watches, for example, that can produce waveforms that are changing how education's operating. It's customizing the content. So if you have a mental disability, if you speak a different language, if you just need more time on something, the AI will reconfigure what's in the LMS so that students can complete the work and complete it more easily for them.
Got it. Okay, Ben, I am very grateful to you for giving such an interesting account, and absolute very best of luck with your further development and research. Well done.
I appreciate that, Felix. Thanks
Cheers,
for having
Ben.
me.
Bye-bye then. Thanks for listening. Ping me on LinkedIn if you have any ideas on new subjects or guests.